Good morning, Dr. Richard Buckley here with team at MilfordMD. This morning's project is tuning up the arms and the upper raw rolls, the axillary fat pad, and then there's this little bit of extra skin that likes to be sort of just down below the armpit. We're actually going to do a little axillary tuck. One of our patients recently, she had a tummy tuck. So it's also abdominoplasty, right? So she called it a tummyplasty. So I don't know, this is like an armpit plasty, something like that, armpit tuck. You know, there's that skin that kind of bulges up in the front. We're going to get that tucked up in there, and bulges in the back. We're going to get that tucked up in there. And then, you know, with arms, sometimes there's a little fat, so we do some liposuction. Sometimes we do some lasering to get a little skin tightening going. Sometimes there's just some extra skin that hangs down, bothersome. So much as we can trim skin off the abdomen and do a tummy tuck, or trim skin off of the upper abdomen and do a reverse tummy tuck, or do a blepharoplasty, a little bit like a blepharoplasty, and if you get extra skin on the upper eyelids, we can trim that off. If there's extra skin on the lower eyelids, we can do a lower eyelid blepharoplasty. Of course, the face might want to have a little nip and tuck, a little face neck lift. The arm might want a little lift as well. It's known as a brachioplasty. And so I've numbed this area, and I had a couple of little entry points. So that's one of them right there. So I was able to go under the skin and do my lipo in here. Are you awake?
I am.
And how comfortable? Totally?
Completely.
Completely. Almost like totally. Completely comfortable. Anyway, you can see I'm doing this and I'm not bothering our patient. So this area is numbed. The rest of the body is not under general anesthesia. There's no general anesthesia. So just local anesthesia for everything we do, known as tumescent anesthesia. It's regional, it's local, just in the area that we're working on. For example, the other arm we're going to get to after we finish this arm, it's not now numb, so I can't work on it. Before I work on it, I have to numb it. So, we did the lipo-sculpting part, down deep, get some of that fat out, get the contours smoothed out. Next step is going to be, I'm going to take off this skin that I've marked here. I had some other markings on here. These were for my lipo. I went up a little farther with the lipo. And the markings are interesting. You know, obviously it's all artwork. One can put them wherever one wants them. But I like to have patients, when they're standing, put their arms back, and then I'll make a little mark. The part that might stick out the most, I mark that. And then I do the same thing in the front. I make a mark here where if the arms are sticking out, we might see something. And then I can look, and there's always a distance between those two. So I work to put my final little thin scar between those lines. So with any luck, if patients are like this, we don't see anything. And if they're like this, we don't see anything. You know, if they went like that, okay, we'll see a little something maybe here, and hopefully it's very fine and nice and not an issue anyway. But if we can so construct the procedure such that whatever we make is pretty well not seen most of the time, then I think that's a home run. So for example, this is kind of the midpoint of the arm right here. So if you were looking from the back, you know, you would see that. This part that you see right here, which at the moment is kind of on the edge of what you might see from the back, is actually going to get spun around a little bit and tucked to the inside when I do this, you know, medial arm tuck. And then this is the bottom incision that's going to come together. It's a very crafted procedure, meaning there are a lot of little interesting details. You know, one could cut through the skin, then you have fat, you know, lymphatics. But instead of doing that, one can actually just take off this little superficial bit of skin, the epithelium, so de-epithelialize. And then under that, you've got this white skin, not fat, that's very, very tough. And it holds the suture really well. So once I get this little bit of epithelium off, de-epithelialization, then I'm going to be able to take this and fold it over on itself, so the blood supply from right there is going to wind up in the center later. And this white part is going to get folded over on itself. Today I plan on doing something that sometimes I do with tummy tucks, which is called progressive tension sutures. That is to say, when we move the abdominal skin down underneath. We can put some stitches as we go along to tack the skin together so it doesn't move. If it doesn't move, it doesn't chafe. If it's not moving, not chafing, probably there isn't any fluid oozing out, and most of the time, almost always, we don't actually use drains with our tummy tucks. But those progressive tension sutures are one of many things that can maybe help make it so one doesn't need to have a drain. I intend to play with progressive tension sutures here a little bit, especially in this middle part, so that even before I put the skin together all nicely, neatly, and daintily, I hope that with those progressive tension sutures have held the skin together pretty well, right in the middle. Then I'll do my deeper stitches, which will even further level things out, and then an intracuticular floral monocryl, and then some glue when we're done. Really crazy glue. And so that lets you know what this morning's plan is. Lipo, we did. Lipo, we did. Didn't do anything with this yet. I didn't numb it yet either. You can kind of see that this skin is a little loose here. I'm going to get that area there tucked up in here. Also, if you look at this, let's say with a critical eye, and it's similar with the tummy tuck, you might say, well, isn't that distance from here to here quite a bit longer than that distance from there to there? I mean, it's like a shortcut on, you could say, a sphere or a circle, right? That's all the way around, circumferential, that's a shortcut. So how is that going to match up with that? It's a good question. And so what we do is we pleat it. If you look at my markings here, that's sort of the halfway point from here to here is there, and the halfway point from there to there is actually there. So you can kind of see that's a little longer than that. So long story short, that skin gets pleated. And actually I intend to try a little bit of a new technique here today. We'll see how that goes. We're always working on the cutting edge, pun intended. So sometimes we do geometric closures. In other words, we could take a scar, and instead of taking it out and making a straight line, we can make a zigzag line, a serpentiginous, squiggly line. We can make triangles, we can make rectangles, we can make half moons, we can make a combination of all of the above. And why would you do a geometric closure? Because it's much harder for the eye to make out the final scar if it's not a straight line, if it's got some other different shape. Similarly here, I can actually do a sinusoidal scalloped edge on the top here, which instead of being straight, now is going to be like this. It's going to actually be longer, if you were to straighten it out, than that, which is just going to help, I think, absorb some of my pleating from down below. We'll see how that goes. So that's my plan, and I'm not going to work my plan now, so maybe we'll bring you back a little bit later after we've moved on a bit. Thank you for watching MilfordMD and team.